right, everyone. Welcome back to our Unclenched podcast. Today, we are going to talk to Dr. Marty Fraschetti. With Dr. Marty, we will be talking about diagnosis. At the end of the podcast, we'll answer a couple of questions from you guys, the listeners. Before we get started, I need to get caught up with my Alex. What's up? What's been happening?
A lot. I mean, we're just kind of regrouping, start of the year, setting goals for this year. Always do that with the girls at the office, with classes we're going to take and all that kind of stuff. So that's been great. Family's been great. And, seeing some different kind of patients. I mean, the same, but a lot of them more complex to treat. I have a patient now that I'm seeing. She's from Minnesota and she comes in once a month, and her name is Catherine, and she has so much stuff going on. And I'm like, wow, we got to really sit and look at this. But she's starting to get better, but I need the help of PT and a cranial sacral therapist, and we found somebody out by her, and just trying to collaborate everything. It takes a lot of us to get on the phone and to talk, but she's turning the corner now. Good. And it's so great to see. But I did a tongue release on her. There were just so many things that were kind of sewn together that now we're trying to unravel the knots. And it's really exciting. It really is. So, that keeps me going.
What percentage of your TMD patients, do you do a tongue release on? Is that like a very common thing for you?
I do it a lot. I do more on my ortho patients, but with TMD, some of my patients, I have to do a tongue release on because their swallow is so impinged, and the way that they're swallowing, and they're recruiting muscles of the cheeks and of the neck. And if I can't get, your swallow, how many times a day? A few thousand, right?
Yeah.
A couple thousand, 2,000-3,000 times a day. Your teeth are coming together. You're swallowing, at least they should be. And when they have an aberrant swallow and things like that, we really dive deep into that, because I think that's one of the contributing factors. That's not the only factor, but that does contribute. So, so everything's been going good. And she just would feel this. She's very in tune with her body, and she would just feel this tightness from her pelvic floor and her feet and just all this stuff, and had been everywhere. And so she's come to me because of everything I had with tongue release and looking at the body and all that. So we're making progress, and her practitioners that she's seen a long time out in Minnesota, are like, okay, good. We're on a good way. And things are holding for her. So that's my thing. And I think I'll be seeing her shortly in the next week or two. So what's been going on with you?
Yeah. Seeing family over the holidays was really fun. What else is going on? I mean, my husband is going to start, he's going to go to Dr. Fraschetti's ortho course next week. So this is really interesting timing that we're doing the podcast right now. And he just finished Core 3 at LVI. We're probably going to have a FMR, full mouth reconstruction, rehabilitation, whatever you want to call it, case lined up for him. And so it's really coming full circle at my practice. I've always been able to offer phase 1 treatment. And there are people that come in wanting phase 2, or that would truly benefit from and can do phase 2. And I wasn't trained in it. So it's really exciting having my husband being very open to getting trained in that, and then we can work together, because really they have to go together. Yeah. So that's sort of what's been on my mind. I did have an interesting experience. Rather than talk about a patient, I was going to tell you about this experience anyway, so we might as well talk now. I had a patient who came to me because she used to be a patient with my mentor. So she's familiar with our practice, but I didn't know her. And she's one of those where she has a pretty severe crossbite, and it's contributed to her migraines, her jaw pain, and the orthotic has helped, but I don't think she's where she wants to be. But the bite is such a big factor that we talked about. We've talked about ortho, we've talked about full mouth reconstruction, all the different options that we talk about, right? a fixed orthotic leading up to full mouth reconstruction. There's a lot of things we've talked about with her. And so she asked for a treatment plan for full mouth just to know, fees and everything. So I gave it to her, and then I got a call from her dentist, who I didn't even know who her dentist was because she didn't list it on the paperwork, and he didn't refer her to me. And he
Yeah.
called me and chewed me out and said he referred her and I should have collaborated with him if I was going to do any restorative work. And I said, first off, you didn't refer her. And second off, like, she's in pain. So if you're going to do any restorative work, are you measuring EMGs? And he wouldn't answer my question because he's not.
Right.
And then he got even more mad. Well, do you know that I teach occlusion and I teach full mouth reconstruction in this? I won't say where he teaches.
Which camp?
Yeah, which camp. But I said, but if you're not measuring EMGs, what if you make this patient's pain worse? Unintentionally, of course, but you restore her teeth and her pain gets worse. Then what? Didn't have an answer, just wanted to yell at me. And I mean, he didn't refer her to me. So it's kind of a HIPAA violation to even call me about her, right? So anyways, it just turned in this big whole thing. I mean, I don't know how you do it. Like, do you feel like do general dentists refer to you? And like, how do you manage that? Like, it's such a crazy thing.
Yeah, I do have general dentists that do refer to me.
Okay.
And I either call them up, tell them what I found, tell them what we're doing, and if they should have any questions, let me know. But I've been doing this a lot longer, so I think people are used to me. You know what
Well,
I
but
mean?
you've been
Here you
doing
are,
phase
some young girl, and they're
yeah.
like, "What the hell's she know?" You know
Well,
what I mean? They
also,
don't give
I
you
haven't been
credit.
doing phase two. So I haven't been
Right,
stepping on any toes at all.
right,
I'm like
right.
dipping my toe into it and already I got yelled at. I'm like, oh my gosh.
Yeah, well, you'll get used to it.
Probably.
You'll be able to pull those arrows out of your back pretty easy before you know it.
I love it. Well, on that note, let's bring on Marty.
Hey, Marty.
Hello. That was
How are
interesting.
you?
I'm good. How are you?
That was interesting.
Good, good. So, yeah, we try to be a little interesting here.
Yeah, that was boy, I'd like to meet this guy.
Yeah,
Whoever it is, you know.
Oh,
yeah.
he was so mean to me. I was just like, wow, okay.
Right. Like, okay, right. So, Marty, I've known you a long time, and I know you've been practicing a long time, and I think even longer than me. So,
Cool.
tell us a little bit about your journey and how you got into neuromuscular.
Oh boy. You
Yeah.
know, on the one hand, I'm blessed to still be able to do this.
Yes.
Okay.
Agreed. And we're blessed to have you out there teaching and helping.
If you would, okay, I graduated in 1984.
Okay.
This is where this started. And I go all the way back to dental school because there was a teacher of mine named Gary Wolford.
Love Gary.
Gary Wolford was the head of oral surgery at Henry Ford Hospital while I was in dental school, but he taught at fourth year, he taught a TMD oral surgery combo course. And I didn't know a lot, but what he said made sense to me. It just made sense. And anyways, I graduated, and the practice that I took over actually belonged to a friend of mine from high school's father. And I had no idea what he did other than he was a dentist. So I went in there one day. I figured the guy's got to be ready to retire because he's as old as my dad, and my dad's retired. So I went in there, and he said, yeah, I got a couple years left in me. And I didn't know what he did, but I found out he's very progressive. He was a panky guy, a lot of reconstruction. Into TMD, he was in Gelb appliances and all that fancy stuff back then. He did straight wire functional orthodontics, who he learned through Walter Brem. I don't know if you remember that name.
I do.
I considered him the godfather of straight wire orthodontics, and they happened to be friends. So he told me, he said, look, if you're going to work here, you're going to have to learn how to do ortho. You're going to have to. He says, and I'm not going to tell you why. He says, but you'll find out down the road why you need to know ortho. So I did. I went, it was kind of a 4-module course over 2 years. You know, it was like each module was 4 weekends. So I was doing straight wire. And in the beginning of the class, everybody's talking, what do you do? What do you do? Well, I didn't do anything. I didn't put a bracket on in my life. And I had these guys in there. By the way, Gerber was taking the same course at the
Oh,
time.
wow.
Yeah. So, I haven't
That's
done
who I
anything.
learned from a lot.
And I'm like, I don't do anything. And everybody's up there saying, well, I do pioneers, I do Frankels, I do this, that. And I'm like, what? So I found out those were functional appliances. So I thought maybe I should learn something about those as well. And so I went through the whole straight wire program, and I started taking functional appliance courses. And then Gary left the hospital, and he opened up a practice a mile down the road from me.
Wow.
Yeah,
Lucky.
right down the road from me. Calls me up one day. This is like fast forward 3-4 years. Calls me up one day. He says, hey, I know you're doing ortho. I've got these patients. Can you help me out? I need a little leveling, aligning. I need some vertical. This, that. Yeah, send them over. So he'd send these patients over, and I do the ortho, and I'm like, is this what you want? He goes, yeah, that's great. Then he started sending me ortho patients, and I'm getting these patients, and I'm looking at them, and I'm going, they look good to me, Gare. What do you want me to do with them? Their teeth look straight, right? Everything looks good. And he goes, no. He says they're closing 4 millimeters posterior to trajectory. I'm like,
Oh.
what are you talking about?
Yeah.
He says, come down to my office. So I went down to his office, and at that time he had a K6. I don't know if you met it.
Oh, yeah. I've
Yeah.
seen his K6.
It was a K6, okay? And he explained to me this whole thing, and it started to make sense. And I'm going, oh, yeah. You put the functional stuff together and the straight wire, and I get what's going on here. And he goes, look, I'm going to hook you up with a couple people I want you to meet, and you're going to go to Pittsburgh, and Gerber and Mazzocco and all those guys. So long story short, I go out there. I met Mike Mazzocco, was the first guy I met, who I ended up teaching with, okay, down the road before he passed away. And that's kind of how my neuromuscular journey started. I didn't know I was doing neuromuscular at the time for Gary. I didn't know what I was doing.
Sure.
I didn't even know who Mazzocco was. He just told me, go look for some guy named Mike Mazzocco. I pulled into that hotel, and I sit in the back of the room, and this guy looks at me, he goes, what are you doing here? And I said, I don't know. I'm supposed to look for somebody named Mike Mazzocco. He goes, well, that's me. And so we ended up talking the whole weekend,
Yeah.
That's really how it started. And, just did the course. And then, as far as functional went, there was a guy that was supposed to be kind of the guru of functional appliances named Brock Rondeau out of Toronto.
Oh, yeah.
I've learned from him too.
I've taken his course too.
Well, I didn't want to go to Toronto. Okay. So I didn't. So I noticed that, oh my God, he's coming to Detroit. This is great.
Yeah.
I'm going to go. So he came to Detroit, and I took the course, and me and a friend of mine who was doing straight wire, we were sitting next to each other, and Rondo's talking, and there's a break, and we're looking at cases, and in the back, me and this guy were bending wires. We're doing utility arches, right? And Rondo comes over, and he looks at me and goes, what are you doing? And we told him, he says, you know how to do that? And I said, yeah. So we talked. He goes, look. He goes, I got this course in Chicago with about 100 people coming. I can't handle this course. Would you be willing to work with me and help me? I said, sure.
Wow.
And that's how I ended up working with Rondo for about 10 years in Chicago, teaching straight wire, functional, and stuff like that. So this neuromuscular is not something I said, hey, this is what I want to be when I grow up. It just kind of landed in front of me.
I love that.
But what I want to point out to our listeners is that you're not a trained orthodontist.
No.
And nor am I.
No.
And
that's a plus.
Yeah, you don't have to go to be a trained orthodontist to learn this.
No.
Because trained orthodontists don't know this.
No. And it's loosened up over the decades, because when I was learning ortho, talk about darts, the orthodontists would condemn you.
Sure. Well, they
did not want a general dentist doing ortho. And the reason they didn't is they didn't want us to see their secrets of what they did not do.
Yeah.
Okay.
I have seen so many finished ortho cases that just my blood will start boiling. It's not pretty.
My mentor, who the one that the practice I took over, he told me, he said, your first ortho case will be better than most of the orthodontist cases you see.
Sheesh.
That's what he told me.
Yeah. Yeah.
I said, wow.
Yeah.
But yeah,
Well,
there was a whole, yeah, it wasn't that friendly back then, you know. That's how I got into it. It's just one thing led to another, and I met the right people.
I
And
love it. I love it. Well, Dr. Marty, you probably know I go by the TMJ doc on my social media. Can
yep.
you explain to our listeners, most of whom suffer from TMJ, TMD, how you define a TMJ doc?
Well, we all know there's no such thing as a board certified TMJ specialist, right?
Yes.
I mean, we have oral facial pain specialists, but most of them will tell you they don't treat TMJ anyways. They're in the pain game. So the first thing I often question is, when you say TMD, what does that really mean? You know, too much disagreement, right? Is that really what it means? Are you a TMD disorder, or are you a TMD dysfunction? Which one of those D's are you? Because if you're the disorder, by definition, disorder means unknown etiology. Okay.
Oh, there you go.
So there you go. If you're dysfunction, that's what we are. We treat dysfunction head to toe. So defining what a TMJ expert or doctor is, in my mind, it's having the knowledge and training to comprehensively diagnose and treat all the postural occlusal disorders within the scope of your profession.
Yeah.
Okay.
Yeah.
You have to.
That's a
great.
great answer. I love it.
Yeah. So
That's
I know.
it.
I know, sorry, I just started thinking, and I know that you lecture a ton on TMJ diagnosis. So is there a common misdiagnosis given to patients by their dentist, or do they just not know
How?
who to diagnose and who not to diagnose? Like, tell us a little bit about that and what you've seen, because, you are kind of like the guru and you've been out there a long time.
You know, it isn't so much the misdiagnosis as there's no diagnosis.
I see that a lot too.
There is no diagnosis.
Right.
And, you don't have the ability or knowledge to begin to separate symptoms and signs and dysfunctions into, well, what is a diagnosis? I mean, what is the diagnosis? When people, and I get this all the time, people always throw out what they're doing, their treatment, but nobody ever precedes it with what was the diagnosis.
How do you define a diagnosis?
An alteration in physiology and or structure that results in a pathology or dysfunction. It's a cause.
An alteration.
Okay.
Okay.
You have to backtrack. Well, an internal derangement is not a diagnosis. Okay, backtrack. Well, why do I have an internal? What caused that? Was it a growth, development? Is it now a deficiency? Airway, tongue tie, all that stuff. It doesn't, you're not born with a tongue tie. Okay, it's coming. Something's going to make that happen, right? It's developmental. And if you don't take care of it, then it becomes a dysfunction or a deficiency as an adult.
Well, some babies do have a tongue tie and have
Yeah,
to
well,
get
yeah, okay, I'll give you.
So I don't
I'll
want
give
our
you the-
listeners to be like,
Yeah, I'll give you the function.
what's he talking about?
Yeah, I'll give
Yeah.
you that. Yeah, I'll give
Okay.
you that.
Okay.
But on the whole,
Right.
the what do you call it? The myofunctional part. It's not like all of a sudden we're myofunctionally have a problem. Something made that happen.
Sure.
Gotcha.
Yeah.
Gotcha.
And
So,
that's what you got to go back to. That's what you got to go back to.
gotcha.
That'll give you your diagnosis, right?
Okay. So I don't deal with insurance, but sometimes my office fills out forms with diagnostics codes, and I want to help my patients to possibly get something back from their insurance, like traditional insurance diagnosis versus a comprehensive, systematic neuromuscular diagnosis. Like, our insurance is ever going to look at a comprehensive systemic neuromuscular diagnosis? I mean, they just want a code number like muscles are tender
Mhm.
or, internal derangement or locked joint. Like, what do you think about that stuff?
I don't think it'll ever happen in my lifetime.
Okay.
I don't think it's
Um,
gonna
Thanks.
happen either. Sorry.
but you got to remember, insurance is they're in the money game, right?
And it's
Right.
getting worse. Coverage is getting worse. It's not
So,
gonna get better.
and I have copies from the oral facial pain guys of their codes and everything they use. And everything on there is based on, if you want to get paid, you better hit one of these codes.
Mm-hmm.
Okay, so those are insurance diagnostic codes to get paid. All right? I want to get paid. So you have myositis. You have an internal derangement. Well, okay, we know those are symptoms. If I bill for an abnormal closure pattern, right,
Mm-hmm.
due to a maxillary AP constriction, I'm not going to get paid. And the patient's not going to get paid. But that's your problem.
Right.
That's your problem. So, the one thing I often think about too is many doctors, I don't take insurance, I don't participate, and we're non-par. Okay, you're non-par, but have you taken yourself out of their code game? Are you still referencing their codes and their definitions of and their diagnostics? Are you still referencing that? Even though you don't take it, are you still using it?
I do. I try to
I do
use
too.
it just to help them get a
To get the
few
patient to
pennies
get
on the
paid.
dollar,
Yeah.
And it almost seems like you're just listing whatever symptom or what you've seen on an X-ray or an MRI or whatever, but the insurance, I don't even think knows what else to do with what we are planning the treatment protocol. Like, they don't even understand what the heck we do, nor has an insurance ever called me to say, "Can you please talk to a dental advisor to let them know what you're doing, why you're
Yeah,
doing it?"
that's never
Or
happened to me either.
never,
Yeah.
No,
never.
they're
Yeah.
not in the patient game. They're in the money game.
They are.
Right.
They're for-profit
They're
companies. They're not.
they're for-profit companies,
Yeah.
right? And they're gonna, I mean, I'm upfront with, when patients come to you, when a TMD patient comes to you, do they really know, the majority of them, do they really know who you really are and what you do? They may get a referral, but, I look at them and I go, by you coming here, do you really understand the difference between somebody who's going to treat you symptomatically versus somebody who's going to treat your dysfunction?
Mm-hmm.
And do you know that person is that person before you showed up? I don't
That's a
think
good question to ask them,
a lot
for
of people
sure.
do. I don't think a lot of, so I kind of go through, I said, you got two choices. I said, we can treat you dysfunctionally. We can correct that. I said, or symptomatically. I said, I'll do that. You can go get your Botox anywhere you want. But I'm in the dysfunction game. I said, I treat pathology. I'm in the we are neuromuscular dentists. Physiologic and orthotics are something we talk about every day, right? What is physiologic? What is it? Normal functioning, non-pathologic. That's what we're doing. We have to get you there.
As TMJ dentists, sometimes a lot of us think everything is TMJ because the symptoms can also be TMJ. Is this what's meant as tunnel vision diagnosis?
Now, what I mean by tunnel vision diagnosis is, and I can go back 40 years. We didn't have social media. We didn't have, everybody creating an appliance. We didn't have all this. We had to go places to learn things. We had to have things sent through the mail, and it's kind of a slower process, but I think it was a little more knowledge, and when I talk about tunnel diagnostics, what I mean is young dentists, and I've had them tell me this, they come right up to me and say it. They go, we feel like when we take a course, all we're doing is being sold a product or a system.
Mm-hmm. Mm-hmm.
And they go, we don't feel like we're gaining any knowledge. And I said, well, what you're getting is tunnel diagnosis. They're giving you a product and you're using their system and product and diagnosing based on using their system and product.
Yeah.
Okay. That's what I mean by that. One of the things we're going to talk about in the course next week is exactly that. We're not selling an appliance. I'm not selling you anything. I'm going to teach you how to think.
Sure. I love
Yeah.
that.
Think.
Yeah, that's one of the things that was probably the best thing that happened to me after I got my fellowship from LVI, and then they booted me from LVI. I had to go and learn from other places and then put everything back together. You know what I mean? And see what worked for me. And because I didn't want skin in the game just to be one way, one set of equipment or instrumentation. And that was the best thing. So thank you for kicking me out, LVI. I appreciate that.
Yeah. It was a good thing.
Yeah. So when you're teaching, is there a diagnosis protocol that you follow?
Yeah. Over the years, we've had these, everybody's coming up with these cervical cranial maxillary mandibular occlusal dysfunction, right? And I came up with that a long time ago, and then other people were using it. So I created another one, and I call it PCOD, P/COD 2. And it's postural cranial occlusal maxillary mandibular dysfunction diagnosis. That's what I call it. So I created a system.
That's a mouthful.
It is. So I've created a system where, and there's not always particular order to it, but you got to cover all the bases, that you've got to hit on all this airway. You've got to hit on skeletal, maxillary and skeletal cranial relationships. You got to do the tongue. You got to do all that stuff. And which I think there was a question on what makes it, what makes a TM. Well, one of them is how many clubs do you have in your bag, and what do you know how to do, or what do you want to do? How far you got are you a phase one odontist? I mean, where do you draw the line? Where do you want to go? All right. Do you want to just do phase one? Do you want to be phase two? Because phase one, you're relying on an orthotic, right? And orthotics really are, but I mean, by definition, orthotics basically are made to compensate or support a weak or damaged muscle, bone, or joint. All right. That's what they do. They don't correct anything. They're just supportive. That's it. They're supportive.
Well, don't you think they're correcting like the yaw or the
They're stabilizing it. They haven't.
Okay.
They haven't moved anything. I always tell my patients, look,
I get it.
Here's your orthotic. It isn't going to grow bone. It isn't going to move teeth.
Right.
It ain't going to do any of that.
Right.
And you've got to remember, orthotics have problems. They need adjustments. They can become ill-fitting.
Right. They'll wear down. Right.
The goal here is to get the body corrected so that it relies on itself to readapt rather than rely on a product or an orthotic. That's I'll jump to the end right now, but that's the goal. That is the goal in neuromuscular, is to create an environment for the body to correct itself rather than to rely on something else. And the only way you can do that is what you're doing. The tongue ties, the orthodontics, the orthopedics, cranial people, ETs. I don't touch necks. I send those to my PT guys. They're way better at it than I am. Tongue ties, I don't do. I'm too old. So I got a mild people I deal with, So, you cover all the bases, get everything corrected as much as you can so that the patient has the best ability to readapt to a physiologic environment. That's it.
How can people that are listening to us find someone who can properly diagnose? What are your thoughts on that?
You have to watch your video. Oh, that's really hard because they're patients, right? They're not dentists. And I look at the patient and are they asking, are you asking the question based on what does the patient want to find to make them happy? What is their chief complaint? What is your chief complaint? All right. Might not be pain. So in their mind, maybe if somebody says, well, I can get you out of pain, great. Maybe that's what they would consider a well-rounded TMJ doc. All right.
Sure. It meets their goals.
So you talked about like cause, deficiency, signs, symptoms, diagnosis, treatment versus stability and buying time. Can you like elaborate on that?
Yeah. It's kind of what I've been saying.
Yeah.
If you're, I see a lot of cases where, well, here's my trajectory and here's my orthotic and look at, I finished them here and the patient's comfortable and well, that's wonderful. I said, but can you show me your CBCT? Can you show me your orthopedics? Can you show me what you did to make your trajectory the trajectory?
Explain trajectory to people that are listening.
Well, trajectory is really, I go by the physiologic envelope. Okay.
Yeah, me too.
I don't know if you've ever seen that, the envelope, the cylinder and all that.
Yeah.
All right. Trajectory really, myocentric occlusion is really kind of an AP thing, but it's really the arc of closure when your muscles are balanced and relaxed. Okay?
Right.
Well, the only way we can relax a muscle. We have a tangent. We can relax muscles, but in that moment, you're only relaxed based on what the muscles feel, right?
Mm-hmm.
It's just a muscle. Yeah,
it's just a moment in time.
It's just a moment in time. Scrap that moment in time. You've got to go into the future and say, how can I make sure I have the right trajectory and I have the right corrected deficiencies and discrepancies to make sure that that person stays on that trajectory? Because, and one of the things we're going to talk about in this class next week is I have a list of things that can throw your trajectory out the window. Okay. There are certain skeletal and occlusal discrepancies that if you aren't finished, I don't care how well your full mouth is, it's not stable. Okay. There are certain things that will make it go backwards. You change, and trajectory is not trajectory. Phase 1 and phase 2 trajectory are totally different. And if your husband will find out in the ortho course, if you're doing full mouth, you're treating on trajectory. Okay. I guess that's what everybody likes. But if you're doing ortho, you're actually developing a trajectory. You're building.
Yeah.
You are.
That makes sense.
You're building a trajectory. And the only way you can do that is to make sure everything is in order and where it's supposed to be.
Sure.
Skeletal, dental, posture, neck. It's all got to be in order. And then I can say, yeah, that's the trajectory I want. Right there. You change AP, you change vertical, you change AP.
Yeah.
Mike Mazzacco taught me that.
Right.
From neuromuscular diagnosis to neuromuscular treatment, what really is the end all goal? And I know you answered this already, but I love the way you
phrased on that. Yeah.
But I love the way you phrased it. So if you could just say it one more time. End all goal.
The end all goal is to eliminate and prevent an abnormal closure pattern. Okay? We're all about mandibular position, and we're all about muscles. So you got to make sure, if that's your mantra here, that I'm going to be a mandible guy and I want things opening and closing freely on trajectory, then you have to eliminate anything that can cause that abnormal closure pattern, right? You have to correct all the discrepancies. You know what the abnormal closure pattern is, right? Have you heard of that? Okay. anything that interferes with the way the mandible comes in contact with the teeth. Okay, there are a lot of things that can cause that interference, right? If you don't do enough expansion, if you don't do enough AP, if you don't have enough vertical. They used to say vertical was the kiss of death. I don't know. I think AP is more of a kiss of death than vertical.
I agree.
Agreed.
Agree? Yeah.
Agreed.
Okay. So, and it is an
AP
airway too.
anterior posterior movement, just for
It
people
is
that
an
are
airway
listening.
too, right?
Yeah.
So, yeah, the goal is to eliminate anything that can cause an abnormal closure pattern, and that's everything. That's everything.
Sheesh.
Wow.
So it takes everybody, like I said, I don't do necks or airways.
Yeah.
So you
It
got
takes a village.
to do that. You got to do that.
Yeah.
And I tell everybody every time no matter what I'm talking about, I always try to let everybody know orthopedics and orthodontics is the best kept secret in dentistry.
Mm-hmm.
Mm-hmm.
I know people hate it, and we're going to go through cephalometrics and all that too, but you got to know it.
Right.
You don't know it. What do they say? The less you know, the more normal things look.
Yeah.
Yeah.
Right. And that's how I felt when I was in my learning. I'm like, oh God, now this is another thing I have to look at.
Yeah.
Oh geez, now I got to do this. And now that I've heard this, I got to find out more about it. And, that's like my daughter just graduated dental school. And I tell her the only thing that dental school diploma gave you is it gave you a license to keep learning. And
Mhm.
that's what you just really, really have to do. And she's like, I know, Mom. When are you going to take me to, like Nice? Because I know in a couple years we'll be there for a class. And I'm like, yeah, it's in a couple years. But, she wants to go to these extravagant places to learn. But, it's going to be fun to just see her grow and
That's going to be
learn
really cool for
hopefully a
you.
lot earlier than I ever did.
Sure.
Well, I mean, you guys are in a position, or the younger ones are in a position where they have access to so much information at their fingertips.
Right.
We
didn't have that.
Didn't have that.
Mm-mm.
We didn't have that. I mean, we got things by getting together and going to our study clubs and bringing our cases.
Right.
We couldn't Google a case. I mean,
Yeah.
it wasn't there.
Totally
We didn't
different.
have.
Yeah.
Which I'll be at study club, like I said, in February with you in Chicago. So
That'll be fun.
That'll be nice.
It'll be fun.
Listen, thanks for being on. And we always get a couple questions from our listeners. And here's a question. And I saw this on the forum earlier, the ICMO
I
forum
did today
earlier.
too. I was going to say
so that's kind of
Yeah.
funny. How can I unlock my jaw? I can't open wide. I can only open and get 2 fingers. Dentist told me to eat soft foods and rest it. I've been resting for a month. What do I do? So, okay, Marty, because I had something that I wanted to add to our forum when someone posted on there that their patient couldn't open. But let's hear what you have to say, and then I'm going to add something too.
Okay, my first, and it's always the same. The first thing I'm going to ask is, what was your diagnosis? What was the diagnosis that made your dentist tell you to stick to soft foods? What's wrong?
I
Right?
think the dentist doesn't know. That's
Maybe
why
not.
he said that.
Number 2, is it a mechanical problem or is it a muscle problem? You didn't I don't know. I have to see you. And I was going to bring that up because I was reading the same thing you were today. And that would be my question. I go, well, what did I think I answered and sent an email, and I asked, well, what was the patient's chief complaint? Was there any pain? What was going on? Everything was fine before the procedure.
Right.
Okay, everything was fine. And then all of a sudden, I haven't seen the patient.
Sure.
Okay, but I'm going to suspect, that it is post-injection myositis.
Well, now let me ask you that. Post-injection myositis, though, wouldn't you be able to go in there and manually open, like forcefully, to open more?
Depends how forcefully you want to be.
I'm pretty forceful.
Okay. Again, I don't know because
Yeah.
I see the
Okay,
patient.
so let me ask you this. So if it is a true lock,
Okay.
you cannot have the patient open more.
Uh-huh.
why not use Gary Wolfred's pivot appliance?
That's a possibility if it's a true closed lock.
If it's a true closed lock, because that's worked for me in the past. If it's a true closed lock.
I was going to say that too. If it is a true closed lock, yeah, you could use a pivot appliance.
Yeah.
But you want to hear something else Gary Wolford told me?
What?
He said most dentists will never see a true closed lock in their entire career.
He told me that too.
Yeah. Most of it, yeah. Isn't that
But
weird?
that appliance has worked for me if it was a true closed lock or not.
It could still work. We used, those are pivotal. They're maxillary first molar pivots, right?
Yeah.
We used to use, the guy that the practice I took over, that was probably his go-to appliance for everything. So it did work on a lot of pain patients. Okay. Whatever reason it did work.
Yeah.
Maybe it still wasn't, but it worked.
Yeah.
Right?
Yeah.
If it worked,
I had a patient maybe 6 months ago. Guy comes in, same thing, couldn't open, no pain, just couldn't open. So I did make him an orthotic, but I also said, I still think this is muscle. So I gave him a Therabite to go with it. And over the weeks, little by little, he opened more and more and more, and he finally got back. It was no problem.
Interesting. Well, another question here. Can you help my ear ringing?
Okay. I always cringe
at the ear ringing.
I always cringe when I see docs out there, TMD, say we treat tinnitus.
Yeah.
And the reason I cringe is because we all know about the tensor tympani and all those muscles, and they're all follow the same nerve track and all that as the cranial. We all know that. Okay, so we know there's a relationship between tinnitus, fullness in the ears, and TMD. Okay, great. First of all, make sure you've ruled out any type of neuralgia or neuritis.
Correct.
Okay. Number two, if you've had TMD long enough, you can develop that.
Yeah.
Okay. You can get that. And by the way, I do have another course on when it's not TMD, which goes over that. So what you really want to do as far as somebody that is complaining of tinnitus, and if you want to give them some hope, number one, A, how long have you had it? B, is it unilateral or bilateral? Is it constant or is it intermittent? Okay. If it's constant and it's bilateral, it's a long shot. You may help them a little bit, but it's a long shot.
Right.
If it's intermittent and comes and goes on one side, you got a better shot at getting rid of it. Number three, do the bite test on them. If they get a change in pitch and intensity when they're clenching, good. Your orthotic will help.
Yeah.
So that's kind of that's kind of what I want to know before I say anything to a patient about that.
Right. I was actually just able to help someone with tinnitus, and when he came in for his exam, he said it changes when I move my jaw.
Sure.
And so I said, I think we have a better chance for helping you than like most other people, but I still can't guarantee anything. Like I was very I don't know what's going to happen here. And it did.
I'm very cautious with.
Yeah, me too.
If somebody comes to you and just says that's their only complaint, I'm going to dig a little deep on this one.
I had a patient come to me and that was their only complaint, and he flew up from Florida. And Doug was a great guy, or still is. He's not dead. But anyway, he came up and he's like, Alex, I've been to the Mayo Clinic. I've been to this clinic in Boston. I've been to Cleveland Clinic. No one can help me. And I said, Doug, I don't know if no one can help you. I don't know. You've had it a long time, but let's try it. And I'll be darned if it didn't help him. And he could not believe it. And I was a little bit like, oh my God, this is great. Because I didn't know, because he went to all of those other, in New York. And so we put him in I started with a fixed orthotic, because even though he was from Florida and he was able to wear it, he didn't break it, anything. And he noticed fairly quickly. And now that's not the norm.
Oh,
But then he wanted to fix it permanently, so we did his full mouth, and we're like 3 years out, and he's still good.
wow.
The other thing too is you want to make sure when somebody like that comes in, you're gonna do your cone beam, you're gonna do all that.
Right.
If I see structural issue, you can be an asymptomatic TMD patient, right?
Sure.
You can be that. You don't have to have pain. But if I see structural changes or things that follow the TMD, you know, I I would always say, just because you got everything else but the pain. He goes,
Mhm.
this could be, you got a good shot that this may work. No promises, but look
Right.
at your joints are packed out the back end of your ears here.
Right.
Okay. I mean, you've got constricted arches. You're 99% overbite, right? You can't breathe. You got an airway problem. We got to take care of
Right.
that, right? So you've
Right.
got a lot going against you.
Right.
Yeah.
Right.
That's what I mean when you're making what's a TMJ doc? Well, it's being able to recognize all this stuff.
Well,
Right.
Alex, did you get rid of, was the tinnitus gone or just like drastically
Gone.
decreased?
Gone. He also had pain in his ear. And pain is a little bit more, I think, easier to get rid of.
Yeah.
So I knew I was going to make some kind of breakthrough.
Sure.
And he was willing to try and fly up, once a month or
Wow.
whatever. And yeah, he was a character. But yeah, so it
Well, I'm
was
glad
great.
you can help him. And
Yeah.
thank you, Marty, so much for being on. And I'm
Problem.
excited that hubby's gonna be hanging out with you next week.
So, Marty, is there anything that you can send us about your courses that you teach that we can also put on, for this to maybe get you a little bit of traction, or maybe somebody out there's like, okay, anybody can learn this because you can, and a lot of people don't know where to start. So I think that would be great.
I wasn't planning on. I actually did this in 2001. If you look at one of those slides, I had the first neuromuscular ortho course going, and I had a manual made. We have a manual for it, and I sent you that picture.
Yeah.
Now everything's on, everything's QR code. But
yeah. You could send us the QR code. We'll put it up.
Yeah, we'll figure it out.
Yeah.
But I never planned on rebirthing a neuromuscular ortho. And when I was doing these lectures and NICMO and all that, people come up and they go, "Where do we learn this stuff?"
Right.
God, I don't know anymore. And Gerber's retired, and and finally we just said, "All right, I'll go get my stuff. I'll blow the dust off of it." And
no, I think that's great. And if you ever need any help with anything with the courses, because I've been doing ortho too for many, many years, but be glad to help you. And, we want to give you a shout out though.
Yeah.
We'll do. Yeah. I mean, this is our first one, and we're at capacity. You can't take a whole bunch of people for this.
Right.
Sure.
Right.
So if it gets bigger, it's like, I don't know what we'll do, but it'll be a once a year thing.
Really cool.
And a couple other courses that I'm working on right now that will go along with it, and that's gonna be about it. But there'll be a couple of more we'll do.
Good.
As long as I can do them, I'll do them.
Yeah, that's great. That's great. Well, thanks again for being with us. And we so appreciate you and all that you do for the neuromuscular community and teaching and
likewise
lecturing.
To you guys too. Yeah, keep up, keep going. When one thing Mazzacco, before he passed, he gave, I have all of his research. He gave it to me, and he said, "Your job is to take this and bring it to the next level."
Good.
Nice.
That's what I'm doing. You guys get this stuff now, like I'm doing with Jennifer. I said, you get this stuff now, and you have to bring it to the next level.
Yes.
Yeah.
I love
So
it.
everything gets passed along.
Yes.
And that's great. That's great.
I love it.
As long as it's not forgotten.
No.
Cannot be forgotten. Not allowed.
All right.
All right. Thanks, guys.
Thanks.
Bye-bye.